didn't see you there. I'm Brock. I'm one of the residents here, second year at the Kaiser Permanente Orange County Family Medicine Residency Program. Welcome. Hello. Salutations, greetings. Admiring the view? I would, but I'm facing this way.
Why, hello, Brock.
Oh, hello, boss. How are you doing?
I'm doing pretty good. How are you?
I am living the dream, sir.
Oh, that's great to hear. Why are we here today, Brock?
Boss, I'll tell you this, and to you as well. Virtual learning these days, in this crazy day and age we're living in, blows. And the thing is, we're watching videos, we're reading books, and that's fun. We're learning. But when you're seeing a residency program like this, you want to meet the people. You want to see what we're about, what we do. What people are you going to be working with if you come here? And you're just not going to get that from reading a book, from watching some YouTube videos. You really need to be able to see what's going on. That's why we're piloting this. So this is new. We haven't done something like this in the past. We're setting up a program so that you can see us, so we can see you. It's more interactive, not just reading books. Been in the classroom long enough, so I figure it's time we interact this way. What do you think?
I like it. And the highlight of this program, we designed it.
So, boss, while we have students for 2 weeks, what are they going to be doing for those 2 weeks?
Well, I'll tell you. We're going to be doing some outpatient medicine. We're going to be doing some inpatient medicine. Hospital. We're going to be doing some OBGYN.
Oh, labor and delivery, baby.
Pediatrics.
Kids.
And community medicine. Yes, all of those.
See? So, boss, that sounds great. The thing is, though, I don't know if you're like me. I'm a little slow. What I need is that exact schedule broken down for me, itemized, like in copy and paste Microsoft Word document. I need it blown up like that.
Brock, please, do you know who I am? I got you.
What? This is perfect. Boss, this is great.
I know, I did it. But let's go over it. I know it looks like a lot, and you're probably feeling overwhelmed, but we got you. We got a 30-minute orientation, day one.
Monday.
But let's go through everything, all right.
So, boss, I'm super studious. I want to get a leg up on the competition. I see the day starts at 8:30. When are they supposed to be looking at their patients and learning about them?
That is a great question. So, as you do not see here, that'll be approximately 7 o'clock. So the inpatient team will get signed out around 6 a.m. and whenever that is done, they will forward you the patients that you will look at and you will have the chance to review them on your own time. So whenever that happens, and we assume it's going to happen by 7 o'clock, from 7 till about 8:30, you're going to have the opportunity to read through your patients, look through anything you need to look up, so access up to date, any textbooks you want, and be prepared to talk about your patients. You won't have everything because the chart that you're able to access doesn't include everything. What you will need to do then is right before a morning report, discuss your patients with your team and get the additional information that you want. Morning report starts from 8:30 till 9. Now, morning report is a very awesome time where you get to learn about patients that you're not seeing in the hospital. So these are old patients. You're going to be doing clinical unknowns. You're going to be doing case presentations, and you're going to be talking about pertinent topics within family medicine on the inpatient side. And so you're going to have the opportunity to give a presentation on a topic of your choice, which you'll discuss with your mentor, which we will discuss later in this video. Now, Brock, after all that information, what happens next?
Okay. So if I'm not mistaken, I heard about 7 to 8:30 they're going to be looking at the patient. 8:30 to 9 they're doing that super awesome morning report. So 9 o'clock. 9 o'clock is when we hit it big, rounds. So in the schedule you're going to see 9 to 11:30. It says inpatient, self-guided learning. What that means is during that time, rounds vary from day to day as to how long they take, but 9 o'clock is when rounding is going to start. And so what our rounds are table-side rounds. So we're sitting at a table talking about the patients. We'll go through the list patient by patient, and then we'll discuss the plan for the day, the changes in management, the overnight events, pretty much to encapsulate their clinical course in the hospital, what that day's plan is, and what the residents can expect to workload to be over the course of the day. And so that's the opportunity where whichever patient you are able to follow on the list, you'll have the opportunity to kind of work alongside the residents who will be able to fill in information you don't have, to present one of the patients and kind of try and come up with an assessment, come up with a plan, of course, under the supervision, guidance, and with the help of the residents that you're working with.
So Brock, let me stop you there. What happens if they get the information 5 minutes before rounds? Are they expected to know exactly what to do for everything?
Well, that's a good question. That's a good question. I can't believe something like that would ever happen. It'll happen. And the reality is sometimes labs come back last minute, sometimes a new clinical development happens, and you know what? Are you expected to take immediate new information, integrate it, and immediately know how to change the management for the patient? No. And that's part of the learning process. So some of it is, hey, I got this new information. Honestly, at this point, I'm uncertain exactly how that might affect patient care. And then you can defer at that point to the residents who may also not know. And at that point, it may become a discussion. And then that's how we facilitate our learning, and that's part of the rounding process.
Very, very eloquently said. So they do rounds. So what is this self-guided learning, inpatient self-guided learning?
Right. So after the time when rounds end, the residents will go do their tasks. They'll call consults, they'll put orders in, they'll do their thing. And so that is a good time for you at that point to know, hey, here's where some of the diagnoses of some of the patients were, here's the diagnosis of the patient you're following, and you can take that time to look it up. Look up, how do you manage that? What should the residents be doing? What could the clinical course be? When could we send them home? It's that time to kind of engage in the material and really synthesize what you're learning, so that way it becomes a useful, well-rounded experience.
Exactly. And I will say, the information and knowledge that you are going to bring to the team will be vital. It'll help the team look up things they may not otherwise have the time to look up. So we want to make sure that you feel like your contributions are going to be helpful, and so whatever you bring to the team and the time that you spend looking things up is going to be very beneficial to everybody. So thank you.
Muchas gracias.
I don't know any other languages, so thank you. So Brocky, I understand you want me to learn. I understand I'm poring over books, looking at up to date. What am I going to do with it? Am I ever going to use it again?
Abbas, please. Of course. Absolutely. And the thing is, too, sometimes the more you learn, the more questions you end up coming up with. Or the more you want someone else who's seen it before to talk to you about it. We got you. So if you look at the schedule, after the self-guided learning, so from about 11:30 in the morning Pacific Standard Time to noon, what you're going to end up having is you'll see inpatient MM, stands for mentor meeting. And so that's supposed to be protected time with the rounding physician, the attending, who's with the service that week, to carve out about a half hour every day to just kind of peruse some inpatient topics with you, maybe go in depth more on some of the patients we're seeing, to provide a little bit more medical context to further supplement and round out anything that you're reading about in the books.
Yes. So essentially, that is your protected time to talk to an attending physician, which is amazing.
They're pretty good. They're pretty good.
So what are we going to do after that? Well, 12:40 to 1:30, you're going to be doing noon conference. Not you doing noon conference. You're going to be learning about things in noon conference. Our noon conferences are designed to be pertinent to the outpatient clinic, sometimes inpatient as well, but it's to help us develop more knowledge that'll help us in clinic. We get people, we get specialists from all different specialties come in and give us talks. We sometimes give talks ourselves, and you on the outpatient side will give a talk, but we'll get to that a bit later. Anything else, Brocky?
I think that about covers it.
So that was your morning. So Brock, are you telling me I'm going to spend 2 weeks learning about adults?
Absolutely not. We're family medicine providers. We see children, we see babies, we see the elderly, we see them all. We want to integrate that too and make it realistic to really round out that family medicine experience. So if you look at the schedule, afternoon, Monday, Tuesday, peds self-guided learning. We will provide to you some sort of pediatric topic, be it a particular topic at large, a paper, some sort of educational beneficial material. And then you'll notice on Tuesday and on Wednesday in the morning it says Mentor Meeting Peds. A way to interact further with our program. A resident in the program will sit down for a half hour and talk to you about that particular topic and that information to debrief, give you a chance to ask questions, go through the material, and meet another person in the program. All good things to happen all at once.
Definitely.
Now, we'll look at Wednesday. Mock cases. I'm excited. Tell me about it.
All right.
Tell me about it.
So you're going to have the opportunity to flex those problem-solving skills and really show what you know. So you and your group that is coming to rotate with us are going to come together and discuss clinical unknowns. You are going to go through the problem-solving exercise of asking questions about the history, learn about the physical exam, and integrate that into and decide what you want to order as labs, imaging, and figure out what your assessment and plan is. Now, you're going to be doing that with us, so yay, and another attending physician. And it's your opportunity to really get to know how we think as a program and have fun with it as well. How does that sound, Brock?
The goosebumps are coming out right now, the goosebumps.
All right, and then let's finish up the week. What is community medicine SGL?
Community medicine. So some say that's important, and the reason it's important around here, so we're in Santa Ana, there's a very large, underserved, predominantly Spanish-speaking Hispanic population, there's an immigrant population, health disparities are real, they exist here even in our own community where our clinic is. And so it's our due diligence to understand the community, understand what's going on, and be a resource. And so even our program, that's something that's important. The self-guided learning opportunities, Thursdays and Fridays in the afternoon, are where we'll be providing some information to you via whether it's YouTube videos that are around specific community medicine topics or topical reading, give you some time to kind of understand what's going on and how you can make a difference. Saturdays, if you look on the schedule, it's going to be community medicine here. That's going to be through our Lestenac free clinic. So that's something that we do as residents. We spend some time there, and that's working with predominantly Spanish-speaking patients who have limited or no medical coverage so that we can provide a medical service for them. So you'll be able to spend some time with the attending that morning via this virtual encounter to kind of discuss some of those topics that you look at on Thursday and Friday, and also to hear about some of the cases that the residents will precept that day in the clinic.
Exactly. So you get to kind of get a feel for what it is that we're doing here at Kaiser in community medicine. So that basically rounds out your inpatient week. Or does it? Case prep. What is that? And to encapsulate everything that you've learned over the week, you'll be giving a short presentation during morning report, either Thursday or Friday. Isn't that great?
Presentation? You mean something that they'd have to do all by themselves? Because if so, that sucks. Certainly there must be somebody helping them carry the weight of this project.
Absolutely.
I cheated myself like I knew I would.
No. You're gonna have help. See, when you start here, for the entirety of the 2 weeks that you're here, you're gonna be matched with one of the residents here in the program. They're gonna serve as your mentor for while you're here, the entirety of the 2 weeks that you're here. So if you'll look at the schedule, 5 to 5:30, on at least Monday through Wednesday here, you're gonna see case prep. What does case prep mean? That's dedicated time, 30 minutes worth, where you're gonna be able to talk with the resident that you're paired with. And so they're gonna serve as a resource to help kind of organize, choose topics, review the topics, discuss how you wanna present, what you wanna present at the end of the week. Also, the residents here, they're gonna be the best in terms of knowing the ins and outs of the program. They'll be an invaluable resource in terms of asking anything you wanna know about the program, how it works, any questions you may have. They'll be able to answer and talk to you throughout the entirety of your 2 weeks while you're here. And so they'll serve as an excellent resource throughout the entire time. And that is gonna sum up and wrap up that inpatient week here.
Yes.
I'm sure everybody feels much better after hearing that.
Definitely.
I told you I was trouble.
doing all that on inpatient, how are we doing clinic on outpatient?
Good question. So, what's going to end up happening is you should have affiliate access to our medical record system. So, from the convenience of home, you'll be able to see and review patient charts. So, on clinic days in the morning, it's different than rounding. What'll end up happening is you'll be paired with one of the attendings that we have here in clinics. And so, they should be able to send you some of the patient information so that you'll be able to find them in the outpatient chart, kind of review them, see what's going on. You'll be able to talk through different cases with them, either expanding on a differential diagnosis, talking about plans, talking about pertinent history, those types of things. And it'll be kind of realistically seeing what happens here in the outpatient setting. With different physicians, you'll have a broad, at least 5 days worth of seeing different attendings here to get a certain amount of exposure that way. That's gonna be clinic.
That sounds amazing. So what about the rest of it?
I was supposed to prompt that, wasn't I?
You were. But I'll just go ahead and say it. So, is this basically inpatient just with outpatient stuff? Yes, it is. But instead of doing peds, because we are family medicine and we see OB, we have OBGYN. And so you're going to be going through the same thing where you learn something the day prior and discuss it with our amazing residents. So a resident and yourself will talk about your reading the next day, expand on it, maybe even do a few cases if you have time. Now, similar to inpatient week, you will also be doing mock cases. And everybody will come together for those mock cases with us. Community medicine's the same, and it's a pillar.
Santa Ana. So to fully encapsulate what you were able to learn and experience throughout the outpatient week, on Thursday or Friday during noon conference, you'll have a short presentation, about 10 minutes in length or so, on either a particular outpatient topic of interest or even a case that you saw during the week. So boss, how comfortable are you with inpatient medicine? You think present a patient?
No. Can you help me?
All right, I got you. So when it comes to presenting your patient on rounds, every place is going to be a little different. And so we'll kind of go over a general format for how to do it here. It's a good generic format that'll get you through most places, and it kind of helps keep things organized. So that way people can follow what you're saying, the clinical information is presented clearly, and actually, honestly, knowing how to present a patient in the morning rounds also helps communicate in the future with people like consultants, because they're going to want to be able to know succinct, pertinent history, and that's what we're going to teach you how to do. And so, presenting a patient on rounds, what's ultimately going to start out with each presentation is summing up the patient in what we call here at least the one-liner. One-liner is how you capture the summary of the patient, essentially in about one sentence, if it's kind of complicated, maybe two, to really kind of sum it up, give someone who doesn't know anything an overview about what's going on, what you're doing, what you're waiting for. And so it's got a pretty nice formula and recipe to it, if you will. So if you take a look here, it break it down the same for each patient. Comes down to, who are we talking about? How old are they? So you can say, hey, Joe Schmo, 56-year-old male, and then you bump into pertinent past medical history. So if they're coming in for a cardiac complaint, say, you can say he's got a history of hypertension, heart failure with reduced ejection fraction, he has hyperlipidemia, things pertinent to the heart. Would I need to know he has a history of Baker's cyst if he came in for a cardiac? Probably not. That you could leave off. So you say, 56-year-old male Joe Schmo coming in with a history of this. He came in with, what was his symptom? Did he come in with chest pain, abdominal pain, nausea, vomiting? What did he come in with? Fever. What did he come in with? And then during the initial workup or subsequent workup in the hospital, what did you find? And then what was the admitting diagnosis? And in this case, we can say he's currently on a particular medication regimen, and then it is, what are we waiting for? So this is kind of disposition planning. Everybody in the hospital has a target endpoint for when you're safe to send him home. So let's say we had a gentleman come in for chest pain. And so in this case, you could say, hey, Joe Schmo, let's go back to our 56-year-old gentleman, history of hyperlipidemia, hypertension, heart failure with reduced ejection fraction of 45%, who came in presenting with substernal chest pain non-resolved with home nitroglycerin, found to have a indeterminate troponin 0.08, stable EKG, negative chest x-ray, stable electrolytes, admitted for chest pain, ACS rule out in this case potentially, currently on, you could say he's on aspirin, statin, blood pressure medications, waiting for, and this would probably be the cardiac workup, be it tread no stress, Lexi scan, and that's what we're waiting for. Sum it up that way. The rest of your note, the rest of your presentation is really just going to be your SOAP format. So boss, I just broke it down. How you present a patient on rounds. Did any of that stick? Do you feel like you might be more comfortable? Tell me about how we do that here at KP.
I do. Let's go through it. So we have our one-liner. So patient's name, the age, the sex, what their history is, why they came in, what was the presenting symptoms that they had, why were they admitted, what are we doing for them, and what are we waiting for? That's your one-liner. And you want to make it as succinct as possible, and you want to keep practicing that. Now, after the one-liner, we want to talk about SOAP format. So what happened with the patient overnight, subjective information, what did the nurses say, how does the patient feel, right? Then you go on to your objective information, including your vitals, your physical exam, your labs, and your imaging. And then after that, you bring everything together and talk about your assessment and plan. What do you want to do for this patient? What is your assessment? What is it that's going on with them? And is it getting better? Is it getting worse? Is it the same? And what do you want to do for it? And that is a presentation. Thanks, Brock.
Blew my mind. That was awesome.
And just a caveat, the hospital chart that you're going to be seeing is different from what we see typically when we're physically here. And because of that, there's only a few things that we want you to be responsible for while you are in the hospital. What are those, Brock?
So there's 3 big things that you're going to be able to see in the chart. Probably the most important is notes. So you'll be able to see daily progress note, nursing notes, the history and physical, H&P, emergency room notes. You can see labs. The morning labs each day might come a little bit later, maybe around 7:30, maybe 8 o'clock. It varies from day to day. The third thing that you'll be able to see is the patient's problem list for sure. So that'll show you everything in their medical history. And it'll be kind of nice to sift through that to see what might be pertinent and relevant to the current hospitalization.
Other than that, we will be helping you gather the rest of the data, and we will be working with you to synthesize a good presentation for your patient. Again, we are not here to make you do everything. We want you to learn with us, and we are going to be helping you out as part of a team, and we hope that you will feel that way. And so that concludes our orientation for the program.
In all seriousness, we appreciate you sticking with us. We thought that having a little bit more fun might show us who we are more as people here in the program. It's probably more fun than just reading a sheet of paper. Truly, we hope that you get, by experiencing 2 weeks with us, a flavor of what we're all about here at KPOC with the Family Medicine Residency Program, who we are, what we're about, and if you think you might want to join us in the future. So we sincerely appreciate your interest in trying to rotate through us virtually. It's the best experience that we hope that we can make in this crazy time that we're in, but we really hope that you enjoy your time here. We want you to feel welcome. We really can't wait to meet you.
Consider yourself oriented.
'Cause you're